All right, everyone. So today we're going to be covering the first section of the lower limb. And I'm super excited to be the one that gets to teach you guys the anatomy of the lower limb. Anytime we go into anatomy, the cool thing about it is that it doesn't really change much over time. So once you learn it forever. The bad thing about it is it's a lot of memorization and it's a little bit difficult to teach. My goal for us is to try to take it little bite by bite and learn different sections of the lower limb. And my job is trying to help teach you how to kind of digest it little by little. So what we'll do is we'll kind of start with the topic outline. This is the first in a series of 3 integrity lectures that will mirror the 3 lectures I'll be doing in class. So for the entirety of the lower extremity, we'll be covering the overview of the lower extremity in this lecture, which covers the basic motions, functions, movements, gaits of the lower extremity. It also kind of gives an overview of the bones and joints and the nerves, dermatomes, myotomes, and also kind of an overview of vascular supply. And then over the next 3 lectures, we'll be covering the different regions of the lower limb, starting with the gluteal region today. And then next lectures, we'll be covering the thigh femoral region, the knee, the leg, the ankle, the foot. And those are the 6 major regions. We'll also be covering some of the surface anatomy, so we'll be able to recognize this anatomy on our patients. And then lastly, we'll correlate all this clinically, because really all this memorization doesn't mean anything unless we know how to apply it clinically and learn why it's important that we remember these things for later on in our careers as PAs. So getting started, like we said, we're going to break it down by section. So first section that we have is the gluteal section. And we think about the glutes, when you work the glutes, you work in your rear end. So that's this section right here. Then we have the thigh section, or the femoral section, which encompasses all of this. We have the knee joints, and then we have the leg, which is an important thing to note when we talk about the lower limb. We don't call it the leg like everybody else does. In anatomy, we have special names for everything, and so the leg actually only refers to from below the knee, this area. But the lower limb is the whole thing. This area is actually called the thigh, or the femoral region, in anatomy. So if I hear you guys or catch you guys calling this the leg, then I'll just assume that I didn't teach you very well. The last couple of sections are the ankle and the foot. So we'll try to take it little by little. Like I said, this lecture is mainly just an overview, and then we'll kind of move from there into the different regions. So first we have the pelvic region. And it's important to note that the lower limb is directly anchored to the axial skeleton, the spine, by sacroiliac joint. So these join the sacrum to the ilium, and they're connected by very strong ligaments. You also have the pubic tubercle with the anterior superior iliac spine. You have the posterior superior iliac spine, and the medial margin of the sacrotuberous ligament, ischial tuberosities, ischiopubic ramus, and the pubic symphysis. Those are all major attachments to the axial skeleton. Another important thing that we want to cover kind of up front are the different spaces that we're going to be referring to. One really important space is the femoral triangle, and we have a slide on this later on in this lecture telling us what the borders are of the femoral triangle and why it's important. Another important area or fossa is called the popliteal fossa. This is the region posterior to the knee that's formed by the muscles of the thigh and the leg, and it has some really important vessels and nerves that pass through here. I'm sure you remember from a patient encounter how we felt for the popliteal pulse behind the knee. That's important to note. Then also another important space is the tarsal tunnel as we move down to the ankle area, which also houses nerve vessels and flexor tendons. Now, what's the major function of the lower limb? Well, it really has 2 major functions. One is to support the weight of the body with minimal expenditure of energy. So us as humans have evolved from 4-legged creatures to 2-legged creatures. So we walk upright. And our evolution has led us to the point where we can walk upright and expend a very minimal amount of energy. And this has to do with having the center of gravity where it is, and the lines of gravity, the way that our legs are angled, and the way that the weight is shifted from one side to the other during locomotion, which is the second major function of the lower limb, locomotion, to move around. So those are the two main things. And it's something you don't really ever consider, but if you're walking around, kind of consider how little energy it takes to take one step and shift the weight from one side to the other. It's really pretty effortless, and that's kind of a tribute to our remarkable anatomy of our hips and lower extremities. So before we get into the bones and the joints and things, I think it's important to recap the different movements of the joints of the lower limb. And so let's start with the hip. The hip has definitely the most different movements or range of motion than the other joints of the lower limb. And so just to start, we know there's flexion, which is moving the limb upwards towards the belly, and we have extension, which is moving the leg backwards. And as we'll learn, there's different sets of muscle groups that accomplish each of these range of motions. Then we also have abduction, we're taking away the leg from the body, and then we have adduction, which is either to neutral position or even past neutral position. That's adduction, adding the leg back. And then we have abduction on a fixed or fixed pelvis on abduction of a pelvis on a fixed femur. So anytime we think of the range of motion that the muscle groups accomplish, we have to think of one, the range of motion that it will do on the free limb, which is if I'm firmly planted on my right leg and I abduct my left leg, those muscle groups are abducting my left leg. But if I'm firmly planted on the leg that I'm abducting, it actually moves the torso and the pelvis kind of the opposite direction, if that makes sense, or kind of moves it towards that direction. So anytime you think of the range of motion on a joint, you have to think of it as kind of working against gravity and then working independently. Next, we have rotation. We have internal rotation, which moves the knee inward, right? And then we have external rotation, which moves the knee outward. And again, there are different sets of muscle groups that accomplish these range of motions. And then this figure right here is just showing that if you move the leg in a circle towards the bottom, the foot kind of moving it in a circular pattern, you're getting all four of those range of motions: adduction, extension, abduction, and flexion. The cool thing about the hip is, again, it's a ball and socket joint, so it has a lot more range of motion than, say, a hinge joint, which would be the knee and the ankle. So hinge joints really have two major range of motions: flexion and extension. On the knee, flexion is bringing the knee backward, bringing the heel towards the bottom. And then the other is the extension is bringing the knee back to a neutral position. When we get to the ankle, instead of calling it just flexion extension, it has its own special terminology. So dorsiflexion is moving the foot upward, and plantar flexion is pushing up on our toes. Okay. Now this is kind of what I was talking about before when we were talking about gait. Our body is designed very, very close to perfectly when it comes to distributing weight and minimizing fluctuations in the body's center of gravity, and that in turn reduces the amount of energy it takes to move. And really, the center of gravity of the body really only fluctuates about 5 centimeters both laterally and vertically in those directions while we're transferring weight from one to the other during ambulation. So it's actually very efficient and makes us really good bipedal mammals. So now that we've got the basics underway, probably something you already remembered either from basic anatomy or from patient encounter or, just general knowledge. But now we're going to move into some of the bones and joints and kind of start taking a little bit deeper look into these structures. So here's kind of a bird's eye view of the lower limb and the pelvis. The joint between the pelvic bone and the femur, right? Remember, we have that hip joint, that ball and socket joint. Then we have this big weight-bearing bone, the femur, the angles medially. And then we have the joint, the knee joint, of course, and the other weight-bearing joint, the tibia, that forms the leg. The knee joint, remember, allows for flexion and extension. It also allows a little bit of rotation of the tibia on the femur. Now, then we have the patella, which is the largest sesamoid bone in the body, which is located right here, the knee bone, as they call it. We move down to the leg. We have the tibia and the fibula, not to be confused, not fibia, tibula, right? Sorry, not trying to confuse you here. The fibula doesn't really take part in the knee joint, nor does it bear any of the weight of the leg. It mostly kind of supports the leg. These two bones are joined together by an interosseous membrane, and there's very little movement between the tibia and the fibula. The distal ends of these bones form the ankle joint, right, along with the talus. So we have the medial malleolus, the lateral malleolus, and the ankle joint itself. And just a side note, the ankle is most stable when it's dorsiflexed. So there you have kind of your bird's eye view. Now we'll kind of take it little by little. So first of all, we'll start with the foot, because it's probably the most complicated network of bones that we have in the lower limb. So there are 7 tarsal bones. There's also metatarsals, right? These right here, and phalanges, which is very similar to the upper extremity, although we haven't covered the upper extremity yet. Really, there's 2 major movements at the ankle, inversion and eversion of the foot, and that occurs at the joints between the tarsal bone. Limited sliding movements occur at the tarsal metatarsal joint. You also have some movement of the metatarsals, but it's restricted by the deep transverse metatarsal ligaments that we have here. It kind of limits that movement, keeps the foot stable. At the metatarsal phalangeal joints, you have flexion, you have extension, abduction, and adduction, right? So it's a little more restricted than that of the fingers, but you do still have, where you can spread them apart and get some tree frog toes and then put them back together. So you do have some movement there. Also, you have the interphalangeal joints, these right here, which are kind of the grippers of our feet, right? They allow flexion and extension for us to get a tighter grip on the ground when we're trying to push off or jump, those things. So these do have that. Also, when you're getting lazy and you want to pick up, like a piece of paper off the floor or something, you can grip things with the toes. The bones of the foot are not flat. As we all know, we have arches in our foot. We have the calcaneus, which is the heel bone, and then you have the plantar calcaneonavicular ligament, which holds these two together, and the medial arch. And you also have the transverse arch that goes this way, and the lateral arch. The arch is supported by muscles and ligaments, and they absorb and transmit forces while you're walking and you're standing. So the arch in the foot is what kind of allows some of that flexibility and transfer of weight and force from when you're walking, running, jumping, etc. So now we're going to move up into the muscles of the gluteal region, which consists mostly of extensors, abductors, and rotators of the hip. Remember, if we can remember from the pelvis, the major hip flexors are the psoas and the iliacus, and they originate actually in the posterior abdominal wall and descend through the gap between the inguinal ligament and the pelvic bone and attach to the proximal end of the femur. So those are these here, remember, that pass under this inguinal ligament. Those are the major hip flexors. When we also look at the muscles in the thigh and the leg, we have to think about compartmentalizing these, because there are fascial planes that help separate the different portions of the leg and the thigh. And so they're divided into 3 compartments. We have, and they're divided by, again, fascia, bones, and ligaments. So in the thigh, we have the medial or adductor compartment, which mainly act upon the hip joint. Then you have the anterior or extensor, like we have the quads up in there, and they extend the knee. And then you have the posterior or flexor compartment. Those house the hamstrings, and they generally act on the hip for extension, and then the knee during flexion. then when we get down into the leg, between the tibia and fibula, we have the lateral or fibular section, which everts the foot or brings the foot outward. Then we have the anterior compartment, which helps dorsiflex the foot, bring the toes upward, and extend the digits. And then posteriorly, we have all of that, which help, and it makes sense because it takes a lot more force to push up the entire body than to just dorsiflex the foot. So have a lot more muscles involved in plantar flexing than we do in dorsiflexing. And those are housed in the posterior compartment. Going upwards towards the pelvis, remember there are 4 major entry and exit points between the lower limb, the abdomen, pelvis, and the perineum. So we have the gap. Remember the gap between the inguinal ligament. This is between the inguinal ligament and the pelvic bones. Then we have the greater sciatic foramen. We have the obturator canal down here. And then we have the lesser sciatic foramen right here. And it's important to note what goes through each of these spaces and exit points, right? Entry and exit points. So the lower limb communicates with the abdomen through the gap between the pelvic bone and the inguinal ligament. This gap right here. Remember, that's where the iliacus and the psoas muscles come through, and also the pectineus. We have nerves, major nerves that come through this area, like the femoral branch of the genitofemoral nerves, and the lateral cutaneous nerve of the thigh. We have vessels that come through here, like the femoral artery and vein. Remember that before they pass in this area, they're called the iliac vessels. And then as soon as they pass this threshold of the inguinal ligament, they then become the femoral vessels, right? Femoral artery and vein. We also have some lymphatics. And so remember the whole VAN, right? Vein, artery, nerve. Well, it's actually lymphatics, LVAN, right? So LVAN as we move medially to laterally. This area, as we know from the GI section, it can be a weak area in the abdomen and is often associated with femoral hernias, right? We have this weaker area. All right, so then we know that also that the pelvis communicates with the lower limb posteriorly through the greater sciatic foramen. Remember the greater sciatic foramen? They have that piriformis muscle that kind of lies in here, and the sciatic nerve that comes through there. And then, of course, the superior and inferior gluteal and pudendal nerves. The vessels, again, superior and inferior gluteal artery, veins, and the internal pudendal artery. They all go through this greater sciatic foramen. Anteriorly, you have the obturator canal, which the obturator nerve and vessels pass through. Structures pass between the perineum and the gluteal region through the lesser sciatic foramen, most importantly the obturator internus muscle. Then we have the internal pudendal artery and pudendal nerve that pass out of the pelvis through the greater sciatic foramen into the gluteal region and then immediately pass around the ischial spine, the sacrospinous ligament, and through the lesser sciatic foramen to enter the perineum. So just important little passageways and entry and exit points in the pelvis. Now, when we talk about the nerves, we know that we have both somatic and general sensory innervation of the lower limb, and it's by peripheral nerves that come up from the lumbar and sacral plexuses. So the lumbosacral plexuses in here. And these are the anterior rami of L1 to L3 and most of L4, and then L4 to L5 in the sacral plexus, right? Then the nerves originating from the lumbar and sacral plexuses that enter the lower limb are L1 through S3, and the nerves from the lower sacral segment innervate the perineum. So that's just kind of an overview of the different nerves. Here we have the dermatome. So remember, these are the superficial nerves that are supplied to touch and sensory innervation along the skin. And so if you read the chapter 5 in your textbook, there's a section on embryology and the formation of the lower extremity in utero. And as we know from there, it kind of takes on kind of they call it like a barber pole, where it kind of started one way and it kind of spun around. And so you get kind of this twisting of the dermatomes in the lower leg. So we should, in kind of comparing patient encounter to anatomy, be able to understand where each of the dermatomes could be tested locally to test S2, test the posterior thigh. To test S1, we're going to test the heel and lateral foot, right? So you should be able to know all of these dermatomes and how they'd be tested. Remember that S4 and S5 are tested in the perineum. Movements are generated by myotomes. So we had dermatomes, now these are myotomes. So flexion of the hip, bringing up the leg forward, or the lower extremity, forward, is primarily controlled by L1 and L2. Extension of the knee is mainly controlled by L3, L4. And then if you tap on that patellar ligament, that predominantly tests L3, L4 as well. And knee flexion is controlled by L5 to S2. Plantar flexion is predominantly controlled by S1, S2. And if you tap on that calcaneal tendon or the Achilles tendon, you're testing the gastrocnemius and the soleus. That tests S1, S2. And then adduction of the digits is controlled by S2, S3. Right here. So adduction, closing those toes back together, is S2, S3. So there is a way that you can test the myotomes of the lower extremity. Excuse me. Okay, so large muscles in the gluteal region are innervated by the superior and inferior gluteal nerves. So superior and inferior gluteal nerves are here. Most muscles in the anterior compartment of the thigh are innervated by the femoral nerve. Okay, so most of them, these in the green area, muscles in the green area are innervated by the femoral nerve, except for the tensor fasciae lata, which are innervated by the superior gluteal nerve. Most muscles in the medial compartment are innervated mainly by the obturator nerve, except, there's always except, right? Except pectineus, which is innervated by the femoral nerve, and part of the adductor magnus, which is innervated by the tibial division of the sciatic nerve. Remember, the adductor magnus has that little hiatus in here, and so the hamstring portion of the adductor magnus is innervated by the sciatic nerve, whereas the adductor portion is innervated by the obturator. Most muscles in the posterior compartment of the thigh and leg and the sole of the foot are innervated by the tibial part of the sciatic nerve. That's why when we think of sciatica or pain in the sciatic nerve, we typically think of it as running down the back of the leg and even into the heel area. The exceptions to that rule are the short head of the biceps femoris in the posterior thigh, which is innervated by the common fibular division of the sciatic nerve. Then you have the anterior and lateral compartments of the leg and the muscles associated with the dorsal surface of the foot that are innervated by the common fibular part of the sciatic nerve. So we have those three divisions of the sciatic nerve, right? Now, the femoral nerve innervates the skin on the anterior thigh, medial side of the leg, and the medial side of the ankle. You have the obturator nerve that innervates the medial side of the thigh. You have the tibial part of the sciatic nerve that innervates the lateral side of the ankle and the foot. And then you have the common fibular nerve, which innervates the lateral side of the leg and the dorsum of the foot. Common fibular. Moving on. So talking about the common fibular nerve, a nice segue onto this slide is it's a branch of the sciatic nerve and it curves around the proximal fibula, the neck of the fibula, and it passes from the popliteal fossa into the leg. And the nerve can actually, because of its proximity to the bone and also to the surface, it can be damaged fairly easily by impact injuries, getting hit there, fractures to the bone, or even sometimes if we place our casts on the lower extremity a little too high, can get damage to this nerve as well. Going back to that slide we had at the beginning, we talked about the three spaces in here. Now we're going to talk about the superficial veins and as they relate to these spaces. So as far as superficial veins go, When we think about superficial veins, we think about varicosities or varicose veins. These vessels can also be used for vascular transplantation, like for cabbage procedures of the heart, right? So they harvest the great saphenous vein, they take a piece of that vein, they take it up and place it in the heart to bypass blocked vessels. So the most important superficial veins are the great and small saphenous veins. So we have the great saphenous vein here and the small saphenous vein here. They both originate from the medial and lateral sides, respectively, and a dorsal venous arch in the foot down here. And the great saphenous vein passes up the medial leg and the knee and passes through an opening in the deep fascial covering and the femoral triangle, and it joins with the femoral vein. The small saphenous vein passes behind the distal end of the fibula, and then it comes by the lateral malleolus, and it comes back up the back of the leg and penetrates the deep fascia and joins the popliteal vein in the posterior knee area. Okay, so moving into the bony pelvis is kind of a very busy slide here, so we'll do our best to kind of break it down. So each pelvic bone is formed by the 3 bones. Remember, we have 2 pelvic bones on either side that form the pelvis. Each one of these is 3 different bones put together. We have the ilium, the ischium, and the pubis, and these fuse during childhood. The ilium is superior, the pubis and ischium are anterior inferior and posterior inferior, respectively. So the ischium articulates with the sacrum. The ilium articulates with the sacrum, and the pelvic bone is further anchored to the end of the vertebral column. So remember the sacroiliac joints that we were talking about. The outer surface of the ilium and the adjacent surface of the sacrum and coccyx, the sacrotuberous ligament, are also associated with the gluteal region of the lower limb and provide extensive muscle attachment. So remember, all along here, there's all muscles that attach in that area, especially the upper fan-shaped area of the ilium. This top of the ilium is referred to as the iliac crest, and it extends anteriorly to form the anterior superior iliac spine, and posterior as the posterior superior iliac spine. Let's see. What else is important on here? So we have the inferior gluteal line that originates just superior to the anterior inferior iliac spine and curves inferiorly across the bone to near the posterior margin of the acetabulum. Remember, the acetabulum is this area that articulates with the femur, the head of the femur. Then you have the posterior gluteal line, which descends almost vertically from the iliac crest to a position near the posterior inferior iliac spine. And the gluteus medius muscles attached to the bone between the anterior and posterior gluteal lines. And the gluteus maximus muscle attaches posterior to the posterior gluteal line. So here's the posterior gluteal line right here. Talking about the ischial tuberosity, so the ischium or the butt bone ischial tuberosity is posterior inferior to the acetabulum, and it's associated mainly with the hamstring muscles of the posterior thigh. It's divided into the upper and lower areas by a transverse line. The upper area of the ischial tuberosity is oriented vertically and further subdivided into 2 parts by an oblique line, which descends from the medial to lateral across the surface. So the more medial part of the upper area is for attachment of the combined origin of semitendinosus muscle and the long head of the biceps femoris muscle. The lateral part is for attachment of the semimembranosus muscle. And the lower area of the ischial tuberosity is oriented horizontally and is divided into medial and lateral regions by a ridge of bone. The lateral region provides attachment for part of the adductor magnus muscle. The medial part faces inferiorly and is covered by connective tissue and by a bursa. And when sitting, this medial part supports the body weight. right in here. And we talk about the acetabulum right here. It's a large cup-shaped acetabulum for articulation of the head of the femur. And this bone is a region where all three, the ilium, the pubis, and the ischium, fuse together. So when we talk about the acetabulum, the wall is consistent of non-articular and articular parts. The non-articular part is rough, forms a shallow circular depression, the acetabular fossa, which is right in here. And then the central and inferior parts of the acetabular floor. And then the articular surface is this broad area surrounds the anterior, superior, and posterior margins of the acetabular fossa. And it's smooth, it's crescent-shaped, and it's supports the weight of the femur transmitted through the pelvis to the femur. So a lot of people get confused when we talk about like hip fractures. A lot of people will say that femoral neck and femoral fractures are actually hip fractures when they're actually femur fractures. But it's important to know the different parts of the femur. It's the longest bone in the body, and it's very vascular. It's the thigh bone, essentially, and proximal end has the head and the neck, and the two large projections, the greater and lesser trochanters, and also the upper part of the shaft, right here. So we talk about the head of the femur. It's spherical and it articulates with the acetabulum, like we just discussed. It's characterized by a non-articular pit or fovea, the little pit in this area, that's where the attachment of the ligament of the head attaches. Then we have the neck. And the neck is this cylindrical piece of bone that connects the head of the shaft to the femur, and it projects superior medially from the shaft at an angle of approximately 125 degrees, and then projects slightly forward. The orientation of the neck relative to the shaft increases the range of motion of the hip joint. Then we have the greater and lesser trochanters. The greater trochanter extends superiorly from the shaft of the femur, just lateral to the region where the shaft joins the neck, and it continues posteriorly where its medial surface is deeply grooved from the trochanteric fossa. The lateral wall of the fossa bears a distinct oval depression for the attachment of the obturator externus muscle. The greater trochanter has an elongate ridge on its anterior lateral surface for attachment of the gluteus minimus, and a similar ridge more posteriorly on its lateral surface for attachment of the gluteus medius. Between these 2 points, the greater trochanter is palpable. So on examination, you can actually palpate that greater trochanter, and it's an area where sometimes you get injections for trigger point. The lesser trochanter is smaller than the greater trochanter and has a blunt conical shape to it. It projects posterior medially from the shaft of the femur, just inferior to the junction with the neck. And it's an attachment site for combined tendons of psoas major and iliacus muscles. When we look at the shaft of the femur, it descends from lateral to medial in the coronal plane at an angle about 7 degrees from vertical axis. The distal end of the femur is therefore closer to the midline than the upper end of the shaft. The middle third of the shaft of the femur is triangular in shape, if you can see here. Triangular in shape with smooth lateral and medial margins between the anterior, lateral, and medial surfaces. The posterior margin is broad and forms a prominent raised crest, or the linea aspera, where all the muscles attach back here. The pectineal line, which is right here, curves anteriorly under the lesser trochanter and joins the inner trochanteric line. And the gluteal tuberosity, which is back here, is a broad linear roughening that curves laterally to the base of the lateral trochanter and the gluteus maximus muscle is attached to the gluteal tuberosity. The triangular area enclosed by the pectineum line, the gluteal tuberosity, and the intertrochanteric crest is the posterior surface of the proximal end of the femur. We talked about the hip joint. We're talking about the synovial articulation between the head of the femur and the acetabulum of the pelvic bone. The joint is multi-axial, like we mentioned before, because it's a ball and socket joint. It's designed for stability and weight bearing at the expense of mobility. So movements at the joint, like we said, include flexion, extension, abduction, adduction, medial lateral rotation, and circumduction. When considering the effects of the muscle action on the hip, the long neck of the femur and angulation of the neck of the shaft of the femur must be taken into consideration. For example, medial and lateral rotation of the femur involves muscles that move the greater trochanter forward and backward respectively, relative to the acetabulum. The articular surface of the hip are the spherical head of the femur, again, and the lunate surface of the acetabulum of the pelvic bone. Here's another picture of it. Now, around the hip joint, there's a synovial membrane that attaches the margins of the articular surface of the femur and the acetabulum, and it forms a tubular covering around the ligament of the head of the femur and lines the fibrous membrane of the joint. From its attachment in the margin of the head of the femur and the synovial membrane, it covers the neck of the femur before retracting onto the fibrous membrane. So here you can see it again. The fibrous membrane that encloses the hip joint is strong, very thick, and medially is attached to the margin of the acetabulum and the transverse acetabular ligament, and also to the adjacent margin of the obturator foramen. So there's really 3 ligaments that enforce the external surface of the fibrous membrane and stabilize the joint. We have the iliofemoral ligament. Then we have the pubofemoral ligament and the ischiofemoral ligament on the back. So the iliofemoral ligament is anterior to the hip joint and is triangular shaped. And we have the pubofemoral ligament, which is inferior to the hip joint. It's also triangular in shape with its base attached medially to the ischiopubic eminence right here, and adjacent bone and obturator membrane. Then we have the ischiofemoral ligament posteriorly, and it reinforces the posterior aspect of the fibrous membrane. The fibers of all 3 of these ligaments are oriented in kind of a spiral fashion, and they are spiraled around the hip joint so that they become taut when the joint's extended. And this helps stabilize the joint and reduces the amount of muscle energy required to remain standing. That's pretty cool. So moving on to the vascular supply of the hip joint is predominantly through the branches of the obturator artery, medial lateral circumflex femoral arteries, and superior inferior gluteal arteries, the first perforating branch of the deep artery of the thigh. The articular branches of these vessels form a network around the joint. So the hip joint is innervated by articular branches of the femoral, obturator, and superior gluteal nerves, and the nerve to the quadratus femoris. So here we go. Here's a picture of the vasculature of the hip. We already covered the gateways. This is just another slide that kind of lays out what all goes through each of those gateways. When we talk about the nerves, we already kind of covered them briefly when we did the overview, but I'd like for you to be very familiar with each of the nerves, where they come out, which pathways they follow, and what they innervate. And so I like charts. I think this chart kind of helps me understand where the nerves come from, what spinal segments they originate at, and then what the basic motor and sensory neural functions are. So I would recommend that we memorize this chart and understand how to apply it to questions. When we talk about the femoral artery, we know that it's the major artery supplying the lower limb. It's a continuation of the external iliac artery above the linguinal ligament. And the branches supply most of the thigh and all of the leg and foot. Then we also have the superior and inferior gluteal arteries, and these originate in the pelvic cavity and they branch off of the internal iliac artery. They supply the gluteal region, and the superior gluteal artery leaves the pelvis through the greater sciatic foramen and above the piriformis, and then the inferior gluteal leaves through the same foramen but below the piriformis muscle. The obturator artery, which is right in here, is also a branch of the internal iliac in the pelvic cavity, and it passes through the obturator canal to enter and supply the medial compartment of the thigh. So branches of the femoral and inferior gluteal, superior gluteal, and obturator arteries, together with branches from the interpudendal artery of the perineum, interconnect and form this anastomotic network, the upper thigh and gluteal region. And they may provide, collateral circulation if one of the vessels is interrupted for some reason. Kind of like the body's backup plan, right? So moving on to the veins. Remember, veins drain the lower limb from the superficial and deep groups. Remember, we think of deep vein thromboses. Those are cause DVTs, right? Those are the deep veins. Then we have the more superficial veins, which are like the saphenous veins that are used mainly for harvesting for cabbages and things. The veins generally follow the arteries, so it makes it pretty easy. Like the femoral, superior gluteal, inferior gluteal, and obturator, they all follow the arteries. The major deep vein draining from the limb is the femoral vein, and it becomes the external iliac vein when it passes under the inguinal ligament to enter the abdomen. So remember, veins they travel the opposite direction from distal to proximal. And we already talked about the two superficial veins in the lower extremity. Lymphatic. Most lymphatic vessels in the lower limb drain to superficial and deep inguinal nodes located in the fascia just inferior to the inguinal ligament. Remember, we talked about L-van, right? Lymphatics, and then vein, artery, and then the femoral nerve passes through there. We talk about fascial compartments in the leg, the deep fascia and the saphenous opening, the fascia lata. So the leg has this outer layer of deep fascia in the lower limb that forms this kind of stocking-like membrane, which covers the limb and lies beneath the superficial fascia. And this deep fascia is pretty thick in the thigh and gluteal regions, and that's termed the fascia lata. This in here. It's kind of like a stocking. It helps contain the muscles and helps them contract with more force. The fascia lata is thickened laterally to form the longitudinal band, or the iliotibial tract, or IT band, which descends along the lateral margin of the limb from the tuberculum of the iliac crest to a bony attachment just below the knee, right here. And remember, the tensor fascia lata muscle is partially enclosed by and inserts into the upper, superior, and anterior aspects of the IT tract. Most of the gluteus maximus muscle inserts on the posterior aspect of the iliotibial tract, right here. And the tensor fascia lata and gluteus maximus muscles, working through their attachments on the IT tract, hold the leg in extension once the other muscles have extended the leg at the knee joint. So the iliotibial tract and its two associated muscles also stabilize the hip by preventing lateral displacement of the proximal into the femur away from the acetabulum. Very cool. So here's a better picture of that saphenous opening in the fascia lata. And it's the one prominent aperture in the anterior aspect of the thigh, and it's just inferior to the medial end of the inguinal ligament. It's the saphenous opening, and it allows the great saphenous vein to pass from the superior fascia through the deep fascia to connect with the femoral vein up here. Okay, so now we get to this fun femoral triangle area. So the femoral triangle is this wedge-shaped depression formed by the muscles in the upper thigh and the junction between the anterior abdominal wall and the lower limb. So anterior abdominal wall, lower limb. And the base of the triangle is the inguinal ligament. So this is the base of the triangle. The medial border is the medial margin of the adductor longus muscle. And the lateral margin is the medial margin of the sartorius muscle right here, and the anterior compartment of the thigh. The floor of the triangle is formed medially by the pectineus and adductor longus muscles, and the medial compartment of the thigh, and lateral by the iliopsoas muscle descending from the abdomen. The apex of the femoral triangle points inferiorly and is continuous with the fascial canal, the adductor canal, which descends medially down the thigh and posteriorly through an aperture in the lower leg, right here. The lower end of one of the largest adductor muscles in the thigh, the adductor magnus muscle, and then opens into the popliteal fossa behind the knee. So what's important about this triangle is the femoral nerve, artery, and vein, and the lymphatics pass between the abdomen and the lower limb under the inguinal ligament and in the femoral triangle. So the femoral artery and vein pass inferiorly to the adductor canal and become the popliteal vessels behind the knee, where they meet and are distributed to the branches of the sciatic nerve, which descends through the posterior thigh from the gluteal region. So moving briefly into the gluteal region, we've kind of covered a lot of this already, but just to kind of reiterate and kind of go a little bit deeper, when we talk about the gluteal region, it lies posterior lateral to the bony pelvis and the proximal end of the femur. And the muscles in the region mainly abduct, extend, and laterally rotate the femur relative to the pubic bone. So I think one of the cool things about the lower limb muscles is that if you imagine where they start and where they end, where they originate and where they insert, and you kind of just pull them together, you can tell what action they have on whatever joint they affect. I think it's pretty easy to imagine, if you know where the muscles originate and insert, how they'll move that joint. Gluteal region communicates anterior medially with the pelvic cavity and perineum through the greater sciatic foramen, like we've already said a couple times. The sciatic nerve enters the lower limb from the pelvic cavity, passing through the greater sciatic foramen and descending through the gluteal region into the posterior thigh and then into the leg, into the foot. Here's a nice chart. Lays out all the muscles in the gluteal region, their origination and insertion, like we discussed, their innervation, and then the function. For me, when I'm sitting down and memorizing the muscles in any of the regions of the lower limb, it's easiest for me to memorize based on the action of the muscle. So the function of the muscle makes it easier. So these all have lateral rotation right here. So if you can remember that piriformis, obturator internus, gemellus superior, and gemellus inferior, as well as quadratus femoris, all laterally rotate the femur, that helps me remember, where they lie, what they look like, and what they do. So you want to do that for all range of motions. Figure out which muscles do what movements. So in here you have two groups mainly. You have the deep group of muscles, which are mainly lateral rotators of the femur and the hip joint, and that includes, again, the piriformis, obturator internus, gemellus superior, gemellus inferior, and quadratus femoris. Then you have the more superficial group of the larger muscles, which mainly adduct and extend the hip, and those include gluteus minimus, gluteus medius, and gluteus maximus. An additional muscle in this group is the tensor fasciae latae, which stabilizes the knee in extension by acting on the specialized IT band. So this is your more deep group of muscles. Remember, the piriformis right here is the most superior of the deep group of muscles, and it's a muscle of the pelvic wall and of the gluteal region. It originates from between the anterior sacral foramina on the anterolateral side of the sacrum and passes laterally and inferiorly through the greater sciatic foramen. You have also obturator internus, like we talked about, obturator internus over here. This is like the piriformis muscle, is a muscle of the pelvic wall in the gluteal region. Then we have gemellus superior and inferior, known also as the gemelli, right? It's Latin for twins. It's a pair of triangular muscles right here and here that are associated with the upper and lower margins of the obturator internus tendon. Then you have the quadratus femoris, which is a muscle that is the most inferior of the group of muscles, quadratus femoris. And it's flat, rectangular, below the obturator internus muscle and associated gemellus muscles. Then you have the superficial group. Superficial group includes gluteus minimus and medius. You'll see those here, minimus and medius. The gluteus minimus and medius are two muscle groups more superficial than in the gluteal region. Minimus is a fan-shaped muscle that originates from the external surface of the expanded upper portion of the ilium. And the muscle fibers converge inferiorly and laterally to form a tendon, which inserts in the broader linear facet of the anterior lateral aspect of the greater trochanter. Then you have gluteus medius, which is here, and that overlies the gluteus minimus. It's also fan-shaped. And both of those muscles abduct the lower limb at the hip joint, and they reduce pelvic droop over the opposite swing during walking by securing that position on the pelvis on the stance of the limb. So basically, they just help stabilize a joint as you put weight on the other joint so that the hips don't swing that direction. And both of those muscles are innervated by the superior gluteal nerve. Then we have gluteus maximus. Everybody's heard of the gluteus maximus. It's the largest muscle in the gluteal region, and it overlies most of the other gluteal muscles. So it's a quadrangular in shape, and it has a broad origin extending from the roughened area of the ilium. Remember we saw that on the previous slide. And then the dorsal surface of the lower sacrum and the lateral surface of the coccyx to external surface of the sacrotuberous ligament. And it also attaches to the fascia overlying the gluteus medius muscle and between the ilium and the sacrum. So the gluteus maximum mainly extends the flexed thigh at the hip joint. So through its insertion at the IT tract, it also stabilizes the knee and hip joints and is innervated by the inferior gluteal nerve. Couple more slides. So remember we talked about the fascia before. The tensor fascia lata is a muscle, the most anterior of the superficial group of muscles in the gluteal region, overlies the gluteus minimus and the anterior part of the gluteus medius. So the important thing about the tensor fascia lata, it originates from the outer margin of the iliac crest, and the muscle fibers descend to insert in the anterior aspect of the iliotibial tract. And what it does is it stabilizes the knee in extension and works with the gluteus maximus on the IT tract lateral to the greater trochanter and stabilizes the hip by holding the head of the femur in the acetabulum. And it's innervated by the superior gluteal nerve. Nerves. So we kind of talked a little bit about nerves. We have 7 nerves that enter the gluteal region from the pelvis through the greater sciatic foramen. Superior gluteal nerve, sciatic nerve, nerve to the quadratus femoris, nerve to the obturator internus, posterior cutaneous nerve of the thigh, pudendal nerve, and inferior gluteal nerve. So we have a lot going on here. Lastly, we have the arteries. We kind of already touched on them a bit. Remember, we had the superior gluteal artery that comes as a branch off of the internal iliac artery in the pelvic cavity, and it travels above the piriformis muscle. And in the gluteal region, it divides into a superficial branch and a deep branch. The deep branch passes between the gluteus medius and minimus muscles. In addition to adjacent muscles, superior gluteal artery contributes to the supply of the hip joint itself. And branches of the artery also anastomose with the lateral and medial femoral circumflex arteries and the deep femoral artery in the thigh, and with the inferior gluteal artery. We talk about veins. We have the inferior and superior gluteal veins, which follow the inferior and superior gluteal arteries into the pelvis, where they join the pelvic plexus of veins. And peripherally, the veins anastomose with the superficial gluteal veins, which ultimately drain anteriorly into the femoral vein. So there we have it. A really quick and dirty look at the basics of the lower limb, as well as the beginnings of the gluteal region, the muscles, the vessels, the nerves, and the lymphatic system. So that was a pretty quick hour-long presentation of 51 slides, and it's just the beginning. We just wanted to kind of start you off slow. Let's get into it. When we meet on our next anatomy class, be prepared to do an IRAP based on this lecture and to kind of discuss this again, go through it little by little, and kind of help retain it in our memory. Maybe we have some interesting ways to remember things, kind of just repetition, help us think. And so, as I was saying, just kidding. We will meet during class and cover this, and then be prepared to engage in 2 more lectures and then some review after that's done. So I hope it didn't bore you too much with all of this anatomy. I encourage you to watch this at double speed, a little late now, but and then kind of correlate this with what you read in your book, because really anatomy is a lot of pictures with me talking about the pictures. So if you're someone that needs more text and less verbal, it might behoove you to read the textbook and compare with these pictures that we went through today in our lecture. So anyways, I hope this helps, and I will see you in class very soon. Thank you.